Hello and welcome to this Directions on Oncology Pharmacy Insights discussion, Advancements in and Updates in Therapies for CLL. I am Dr. Allison Duffy, Associate Professor and Clinical Pharmacy Specialist in Oncology at University of Maryland School of Pharmacy. Joining me today in this virtual discussion is my colleague, Dr. Cody Steeves, Clinical Oncology Pharmacist, Biologics by McKesson. Today, we are going to discuss a number of topics pertaining to the treatment, dosing, and administration of BTK inhibitors and other agents for patients with CLL. Let's get started on our first topic.
So Dr. Duffy, what are some of the current NCCN frontline treatment options for patients with CLL, including some of the rapid shift we've seen in therapies, some triggers to initiate therapy, as well as the goals as we move forward with therapy?
Sure. So I think the treatment of CLL has really transformed over the past 6 years. We're really getting to have a better understanding of CLL's biology and some of the prognostic indicators. And so these new therapies are really allowing for treatment without some of the traditional chemotherapy agents. And so as pharmacists, we are likely to encounter these patients in many different settings. Previously, single-agent chemotherapy such as alkylating agents were used, or single-agent monoclonal antibodies such as CD20 monoclonal antibodies, moving to chemoimmunotherapy, so combining different drug classes. And now more and more we're seeing what we call our small molecule inhibitors, which do include the BTK inhibitors, using those as single agents or more commonly in combination. And that's where the pipeline and future directions are really moving to as well, with combination therapy, as well as more potent, more selective targeted therapies. In terms of triggers to initiate therapy, the clinical course of CLL really does greatly vary. And so some patients with aggressive disease are certainly at risk for early CLL progression and death if they're left untreated, while a significant portion of patients actually never require treatment and can be managed with supportive care. So some of these triggers are really related to disease burden and threatened end organ function, such as pancytopenia and lymphadenopathy that is really progressive and bulky. And then I think to address your last question about goals of therapy, this is a malignancy of older generations with a median age of 72. And so with that age comes declining organ function and bone marrow reserve. And so it really does impact our goals. We really need to think about functional status and comorbidities. And so it's incredibly important to find and develop therapies that are tolerable and effective. So generally, we look at outcomes such as overall response rate, progression-free survival, and overall survival. And we know that early progression of disease within 2 years of first-line therapy, as well as minimal residual disease negativity, are key predictors of response. Also, especially in our older unfit patients or those with relapse refractory disease, durable disease control might be a more feasible treatment goal than MRD. So lastly, in terms of the agents available from some of our frontline treatment options, really regardless of age, fitness, deletion 17p, include the following NCCN recommendations. Preferred agents include ibrutinib, which is also a category 1 recommendation, venetoclax plus obinutuzumab, acalabrutinib plus or minus obinutuzumab. And additionally, you may consider using chemoimmunotherapy in certain situations and settings.
And I agree. I think the shift has really changed towards those oral therapies, like you mentioned, plus or minus maybe a CD20 inhibition. But it's been a good thing for patients to have that efficacious options that are oral therapies for them to take.
Definitely.